Welcome to Vet Watch. At DVM 360, I'm your host, Christopher Lee. Our topic today, what surgeons wish GPs knew, smoother referrals and better outcomes. And to help us with this, my guest is Dr. Shadi Ireifej. He is a board-certified veterinary surgeon and the founder, owner, and chief medical officer for Vetriage. Welcome, Shadi.
Thank you so much. Thank you for having me.
All right, so just jumping right in, kind of setting that stage for referral. When you receive a referral, which diagnostics do you wish had already been completed, and why do they matter for that surgical planning?
Some of the factors that surround diagnostics that the surgeon wants comes into play when you're looking at timelines. So, for example, having baseline blood work done, biochemistry profile, complete blood count, having it completed as recently as possible is, of course, beneficial as opposed to having blood work results from several months ago. And some diagnostics need to be repeated because of that. So whatever the general practitioner can do in regard to timeline is an important factor. Another important factor when it comes to diagnostics prior to referral would be the completeness, the thoroughness of it. So we all are familiar with radiographs and how for a surgeon, especially an orthopedic surgeon, positioning matters a lot as one aspect of good quality radiographs. So if the general practitioner collects radiographs for the sole purpose of screening that patient, it may not be to the quality that the board certified surgeon would like. So even though the radiographs might be recent and perhaps helped aid in the diagnosis for that patient, the surgeon may want to repeat them because they're looking for additional views, or perhaps they want to screen other parts of that patient's body. So my point in giving those two examples is to say that the client from the general practitioner ought to be made aware that all of the diagnostics may need to be repeated based on what the specialist wants. They may want new radiographs, new blood work, or new diagnostics in general, things that the general practitioner is not able to perform or did not think of performing because the specialist now wants them. So when you're looking at submitting diagnostics to the specialist from a general practice office, look at the timeline of it, look at the quality of it, warn the clients that maybe some of these may need to be repeated.
So with regard to radiographs, try to ensure that they don't need to be repeated. Does sending them out for consult help or not so much?
So I think that the teleradiology consultation perhaps might be more useful to the general practitioner who's trying to verify their presumptive diagnosis, make sure they're not missing anything, just get clarification before they send the case off for referral. I think that the board certified surgeon viewpoint on that is going to come down to what their own experiences are. So, for example, I might be more comfortable reading plain spine radiographs, but not really great at reading skull radiographs, in which case that teleradiology consultation might be handy for me. But overall, at least in my own personal experience of this 20 years, I don't does not affect me either way, whether there's already a consultation from a radiologist or not. And then also when clients are being referred to me, I'm going to interpret the general practitioner's radiographs as best I can. And usually, if I need something additional, it'll either be I'm repeating the radiographs for whatever reason, or I'm radiographing another part of that patient's anatomy because I'm worried about something else, or perhaps I'm going high level imaging like computed tomography or magnetic resonance imaging. So it's up to the general practitioner, I would say, up to their discretion whether they need that teleradiology consultation. I'm not sure how much of it is even done for their own educational purposes versus just practice defensive medicine, making sure they have a specialist signing off on their interpretation of imaging before they refer or talk to the client. But regardless, I would leave that up to the general practitioner to decide when they feel a teleradiology consultation is needed.
Love it. And from your perspective, what's the ideal way for a GP, how they can ahead of time, kind of regarding to workup, prognosis, cost, all the questions, all the things that the clients want to know?
You certainly want, as a general practitioner, to educate your clients, especially if you've had clients that have been with you for years or even generations of family, right? And you want them they're comfortable with you, and so they trust your information. At the same time, as a general practitioner, you also don't necessarily want to speak out of turn or overstep any areas of medicine that maybe you're just not as clear on, especially if you know that they're going to be receiving another opinion from a specialist. So you speak within your own experiences as a professional, which you ought to do. You speak to things that you know are factual and true, but it's also not wrong to leave things in a gray area or say, you know what, I don't know, but that's why I'm sending you to the specialist. They can fill in the blanks. They have more experience with hemilaminectomies than I do, or thoracotomies than I do. And so let them speak to that. I don't want to say something out of turn. Being candid like that with a client, especially a long-term client who really trusts you, that goes a long way, right? We all have access to medical literature. There's always publications you can review or textbooks. You can always phone a friend to get more information on a case that you want to elaborate further on with a client. But also, general practitioners are busy, and if this is a surgical emergency, you may not have time to do a deep dive over the next week on a disease process or a surgery. So feel free to go up to where you are comfortable with your own experiences, and then leave room for the specialist to fill in the blank from there.
No, that's helpful. And kind of moving on to sometimes when we're trying to move them fast over to referral, such as with an emergency situation. In your experience, what are the most common misunderstandings about conditions that truly need emergency referral and which can wait?
I love that question because we see this a lot, not just in brick and mortar, but even with my telehealth company, Vetriage. I see a lot of patients that are being managed to no one's fault. It's just a matter of experience level. These patients are being managed as an outpatient at a general practice when someone like me looks at the radiographs, the blood work, the patient's condition. My immediate thought is, why isn't this patient being hospitalized and receiving intravenous treatment, for example? So every general practitioner, of course, is going to be different depending on how long they've been in practice and what their level of experience is and what their style is, and client factors and pet factors, financial. But if you break it down to its foundation, there are some pets that can be managed as outpatients. There are others that really need to be hospitalized and in a 24/7 facility being monitored and receiving intravenous therapies, all of that. So to answer your question, one of the biggest challenges that I see when it comes to an emergency referral is setting the client up for what's entailed with that. Your pet is not going home with you after after meeting the clinician at the emergency facility or the specialist. They need to stay there. How many days? We don't know. What are they going to do? Whatever they think is best. What's it cost? You got to talk to them about it. But in general, I've seen the bill go around 1,000 to 5,000 or whatever. Make it where you're setting that client up in a general sense because they're so used to your prices as a general practitioner and so used to working with you on an outpatient basis, to think of leaving the pet in a facility, not just for a day, maybe multiple days, and then spending a multitude more financially for that care. You rather be upfront and mention that to them ahead of time prior to the referral. It also makes the job easier for the referral center because now the client has been prepped, albeit in a general sense, but they've been prepped for what to expect, sort of, and that's good enough. We'll take it because we're trying to admit that patient for emergency care, intensive care, ICU, an expensive estimate, days in the hospital, prognosis discussions. So it makes our job easier on the emergency and referral side if the client is set up that way too. Even though it's general, it's still very, very helpful.
Yeah, when I was the medical director at an ER, I was always trying to my doctors about make sure that they understand the roadmap, right? It's not just this segment of it, right? We can have the initial, there's the surgery, but the roadmap's also going to include everything before and after and anything in between. And the owners need to
Absolutely.
know that.
Absolutely. It can be something as simple as the general practitioner telling the client, we've been trying for the past couple of days, injections as an outpatient. We've tried pills at home. We've tried these all these different herbal interventions and physical therapy. It hasn't been working. I'm asking you to go to the next level here, where they're going to talk to you more in depth about short-term, long-term prognosis, what they have to do to stabilize X, Y, and Z abnormalities, staying in the hospital. This is the next level of care. And so just setting that stage that plainly and also that generically is very helpful.
And probably very specific too, right? There's some dogs that the bandage change may be one cost, and on a very fractious dog, it may be very different.
Yeah, you're
Can
going
you
to
give
tailor the plan, not just in regard to what that client wants, both emotionally and financially, what they can swing, but also what that patient is going to lend themselves to. An external skeletal fixator in a fractious animal may not be the best idea. You're going to be visiting that surgeon constantly for bandage changes, and that pet does not want to be there. And or if you have a pet owner who just can't be at home monitoring their pet with an external fixator on, that may not be the right treatment plan for that patient and that client. So we are constantly trying to almost bargain with the client and the patient to figure out what's the best plan to get this pet to recovery with as little complication and headache on the way there.
only we could bargain with the injury.
Yeah, yeah.
So, can you give some examples of cases where GPs can confidently manage in-house versus those that really should go to a specialist right away?
The referral question, when to refer, when not to refer, there are
Mhm.
so many factors, even outside of medicine, that you have to take into account. So there are some general practitioners that are, and this is not an insult, bare bones. Preventative care, vaccinations, heartworm, maybe spay neuter, maybe some subcutaneous injections as an outpatient, and that's the extent of it. You have others that are almost at the line of they might as well be specialists themselves, right? They've got high-end imaging, they've got abdominal ultrasound, they've got even overnight care, and it's a general practice, but they are managing high-end, complicated cases. So, and everything in between. It also comes down to geographically where you exist. Are there even specialists in your area? Or is the next specialist hours away or even in the next state over? Right? Same thing with emergency care. Do you even have an emergency hospital in your area, or is that going to be a 6 hour drive one way? These things matter. We work with areas on Vetriage where clients have to take a ferry or a plane to get to an emergency hospital. That's not something as simple as just buying a ticket and going. It might be 2, 3 days from now, and you're dealing with the emergency right now. So what can you do in the meantime, right? So when to refer, it starts off with what is a general practice able and willing and comfortable to do, and then what do you have access to reasonably in that area where you live. Now, medically speaking, it may come down to what you know as a general practitioner. What does that patient really need? If you don't have access to something like oxygen and you know this patient is oxygen dependent, well, then there's your referral right there. There's it doesn't even matter what else the pet needs. You know it needs oxygen. That's vital for survival. I have to refer you, right? Or it could be something like to expand from the oxygen example, something like an upper airway obstruction. Maybe you have a dog with acute onset of mandibular lymphadenopathy because it's got lymphoma and now it's having problems breathing. Well, that patient not only needs stabilization measures, but also can we induce this patient with chemotherapy if that's the diagnosis, right? That's a referral case. So it comes down to what does that patient really need in that moment? If you can't supply that at the general practice, not your fault again. You are giving your community a very important medical access, but when it exceeds your expectations, then it's time to go elsewhere.
Now, let's switch the conversation specifically to cruciate. So, your ACL, CCL conversation. So, when it comes to cruciate ligament injuries, how do you explain the different surgical techniques to clients, and how do you help them choose which is the best option for them?
Love it, love it. So, if you look at the literature, if you did a literature search on cranial cruciate ligament tears in dogs, there is a ton. In fact, I would be willing to bet that out of all the orthopedic conditions we see in dogs, the most commonly published topic is going to be cranial cruciate ligament tears. It is so common. And with that comes about 30 plus different surgical techniques that have been published. And I'm quoting that number from when I took my surgery board 15 years ago. There's probably been more techniques since then, right? So out of, let's say, almost 40 different techniques, how do you go through those options with the client? Well, the way I have that discussion with them is I tell them there are dozens of different techniques, some commonly used, some not. It comes down to what the surgeon that you're consulting with is comfortable with. So I'm comfortable with two different procedures, the lateral suture technique and the TPLO, the tibial plateau leveling osteotomy. There are some surgeons that also perform the TTA, right? I don't perform a TTA. So if the client already has come to me with a preconceived notion that they've done their own research and they think this TTA is the way to go, great. I can speak about it at a superficial level, but if that's really what you want, I will refer you to another surgeon who does those. But in general, that conversation is there's 30 plus different surgery techniques. I'm comfortable with two or three of them, and then I choose which surgical technique out of the two or three that I know is best for your patient based on their comorbidities, their age, their size, bilateral versus unilateral tears. Do you have any other conditions, etc. And then we go into a deeper dive on the surgical technique, that specific technique, complications, aftercare, costs, all those factors. So that's how I tend to break it down. We all know that there's not a one size fits all when it comes to surgeries, especially when you're dealing with cranial cruciate ligament tears. And we all know that in my hands, a TPLO is going to have different outcomes than another surgeon who performs a TPLO as well. So that's the conversation that I have with clients when it comes down to trying to decide between. One more thing I will mention, because it seems kind of ridiculous that we have 30 plus surgery techniques for one fairly simple, straightforward disease. And what I tell clients when they ask, why are there so many techniques? I tell them it's usually a sign that we still don't know what the answer is. When you're seeing 30 different techniques for one very specific disease, it just tells me we haven't figured it out yet, even though it's so common, it's so prevalent. And cranial cruciate surgery for a surgeon is their bread and butter. I mean, they're doing a handful a week. And yet I'm not convinced we're treating them the right way because we have so many different options. So that's my cursory discussion with a client. And hopefully for general practitioners who are listening and watching this, hopefully that gives them some insight on how to elaborate on that.
Yeah, and as we talked about before with client expectations, keeping it a little bit vague because that's going to end up maybe going down very different paths for different patients.
Absolutely. In fact, what I'll add to that response, Doc, is that virtual media, social media videos, posts discussing these diseases. So, for example, I have a YouTube channel and I have cranial cruciate ligament videos on there. Perhaps your client wants to be further educated between what you've told them as a general practice a general practitioner, but before they see the surgeon, have them watch a video that you trust, that you've watched yourself, that talks about cranial cruciate ligament disease, and let that client educate themselves from not just a Google search and looking at ilovedogs.com, but actual videos by board certified surgeons who are discussing and there's plenty of them out there, not just mine. You can look at mine and compare and contrast to another surgeon, right? And educate yourself that way too. Give your clients these tools that are free, they're easy to access, so they can be more well versed before they see the surgeon.
No, those are great resources. And for viewers, we will have the links to Shadi's YouTube site down below.
Thank you.
Now, this next part is a little bit maybe controversial, but what are your thoughts about the common GP performed over-the-top stabilization technique? Like when or is it ever appropriate if finances are not an obstacle?
And you're referring still to cranial cruciate ligament disease?
Mm-hmm.
And by stabilization, do you mean like braces and bandages, splints, things like that?
Well, no, like some of them do the surgery with the kind of the over-the-top surgical, where they do, and I know some that have used like a sterilized fishing line to do so.
So just because a board certified surgeon specializes in surgery doesn't mean they have to perform all the surgeries, right? And if a general practitioner is comfortable with a procedure, whether it be something as simple as a spay or neuter or something as maybe complex as orthopedic surgery, it is up to that client or up to that veterinarian, rather, general practitioner, to discuss with the client the pros and cons of referral. So a common phrase would be, ideally, you would see a surgeon who specializes in this for this disease to get this problem fixed. they cost around this much. They are usually booked for about a month or so ahead of time, but they're great. I love them, and you can go there. If you can't afford that, or your case can't wait a month, and there's no other access, or whatever it may be, I have done this surgery before, and I'm comfortable with it. But just realize I'm not board certified, but I've been doing this surgery for X number of years and have pretty good results. I can also do it tomorrow, and I'm much cheaper. But whatever works for that client, right, for their whole world. And so, if you're a general practitioner and you are comfortable with a surgery like that, you've done it before. That is not to take away from your own experiences and skill set. Just because you're not board certified doesn't mean you can't do a fantastic job, right? But you want to communicate with the client and make sure they understand the difference between the two worlds, and then let the client decide what fits best for their own personal beliefs, their finances, that pet. They know their pet best. So when it comes down to other surgical techniques for cranial cruciate ligament disease that a general practitioner may perform, I have no problem with it. Is if that conversation has been had with that client and that general practitioner is comfortable with that, I have no problem with it. Having done traveling surgery before, some of the concerns I have comes down to not even the skill set of the general practitioner. It's things like sterilization techniques, the equipment that you have there. It's basic surgical premises like those that concern me a bit more than can the surgeon, the general practitioner, actually perform this? Because I've seen some pretty gnarly stuff in general practice when they're trying to perform high-end orthopedic surgery. So those are the factors that I'm concerned with more than can they perform the surgery. The fishing line example that you gave, just to do a bit more elaboration on that.
Yeah, and I was wondering too, like that extracapsular approach,
Yeah.
is there certain weight bands that maybe it's working better for and not working better for?
So for folks who don't know, there's three different categories of cranial cruciate ligament disease surgery. One is intra-articular, which I don't know anybody who performs that. That was back in the day. That would be what you would probably receive as a human being, and it's just failed repeatedly in dogs, probably because of the nature of their anatomy and how they behave post-operatively. Then there's the extracapsular techniques, which is the fishing line, where basically you're incorporating a permanent prosthetic in the knee of that dog outside the joint capsule, as opposed to intra-articular, which is inside the joint capsule. And that extra-articular prosthetic is meant to help stabilize the stifled joint until adequate scar tissue forms, fibrosis, over the next 12 weeks. And then once that knee stabilizes, the prosthetic is pretty much no longer needed to help that patient along. And the third category is osteotomies, corrective osteotomy or osteectomy surgeries. Those are your TPLOs and TTAs. So those are three categories. So intra-articular, we pretty much can take off the table. Extra-articular, typically weight-wise, it depends on the surgeon's preference and the case itself. We tend to go, I've done them on all sizes. And but generally speaking, we try to reserve that surgery for patients that are a bit on the lighter side. So the weight cutoff varies, depends, maybe 30 pounds, maybe up to 60 pounds. It kind of depends on the surgeon and what their experience level is. And we all know there are beagles who weigh way more than they should, even though a beagle would be a great candidate for a lateral suture, extra-articular repair. But if you have a beagle that weighs 50 pounds because they're morbidly obese, maybe they need a TPLO or a TTA, something a bit stronger. So it depends widely depending on the case itself and that surgeon preference. I've also performed TPLOs in Chihuahuas and Pomeranians, dogs that are 5 to 10 pounds, right? And classically, we would reserve osteotomies like the TPLO surgery for dogs that are 30, 60 pounds and beyond. So there's a lot of variation depending on what the surgeon wants to do on the patient itself. And then again, you notice a common theme where I keep mentioning finances because it's the unfortunate truth of the matter. TPLOs or osteotomies in general are probably more expensive than lateral suture. So even though that golden retriever would benefit, in my opinion, more from a TPLO, but that client can't afford it, then maybe we have to go with lateral suture and just really help with physical therapy and medications post-operatively to ensure success in that patient. So a lot of different factors. I do want to comment on the fishing line comment because the optics of that are so bad. when we tell a client that we're using sterilized fishing line as a prosthetic for the orthopedic surgery, and that surgery is going to cost you $2,500, it sounds so terrible. And so I just want general practitioners and surgeons to try to use medical terms when you're looking at these, because fishing line is, I don't know, what are they, a couple of cents or a couple whatever at the store. We're using medical devices here, and there are lots of different types of extracapsular, extra-articular prosthetics that we use. So, something like a lateral suture prosthetic is probably a bit better in terms of describing a medical instrument as opposed to a fishing line. So it's just something to consider. That might be more of a me issue with that, but try to use words that are actually medically oriented so we don't sound a certain way.
Yeah, no, I think it's always kind of that range, right? You got to meet the client kind of, where they are, make sure that they're understanding. But yes, I mean, if we reduce everything that we do, it can sound one way versus not. So that is a great point.
You know what I do actually with that? I'll actually have in the exam room, I'll have a sterilized lateral suture and a sterilized TPLO plate, and I show the client, this is the prosthetic I'm talking about for that surgery, and this is the prosthetic I'm talking about for this surgery, right? And so at least they can see it's a real device, and it looks nothing like what you'd find in the hardware store. Like it's got a large needle attached to it. It's got an eye at the thread, right? And so it looks like a real. So I just show them that. That way, that I don't have to water it down. But yeah, whatever you can do, of course, to make sure it's relatable.
Yeah, I think visuals help so much.
Yeah.
So what kind of combination of clinical signs and physical exam findings make you strongly suspect a cruciate tear? And is there anything subtle that GPs should be watching out for?
Yes. So typically with your standard cranial cruciate ligament case, you're looking at a younger aged dog. Typically, they're going to be medium to large breed and beyond, acute onset of lameness, pelvic limb, of course, usually unilateral. Typically, they see the lameness occur after some sort of acute, I'll call it trauma, but something as simple as chasing a squirrel outside or just doing that sharp turn that dogs love to do when they're chasing something, playing, and next thing you know, your dog yelps, and now they're non-weight bearing lame on the affected pelvic limb. And so it's acute onset. By the time they get to the general practice, maybe that pet is improving a little bit, maybe not. The general practitioner is going to perform the physical examination. What they're looking for there, aside the lameness, is they might find muscle atrophy depending on the chronicity of that case. So you're palpating the quadriceps, the thigh muscles, comparing it to the contralateral, presumably normal limb to see if there's any atrophy there. And then, of course, the stifle joint itself, you're looking for joint effusion. You're looking for medial buttress. Medial buttress is scar tissue accumulation on the medial side of the stifle, and that implies chronicity. You may not have medial buttress if the case is para-acute or acute, but for clients who have waited weeks or months before seeing you, there might be medial buttress there. You're also looking for positive cranial drawer sign, which is pretty much pathognomonic for the condition. I say pretty much because I've had dogs with osteosarcoma of the distal femur that also had drawer, and so it's not always there, but it's not always pathognomonic for cranial cruciate ligament disease. But anyway, cranial drawer, where the doctor will stabilize the femur, stabilize the tibia, so one hand on the distal femur, one hand on the proximal tibia, and then move the two bones opposite directions to each other. And when you get that excessive motion, that implies that there's been loss of stability, typically attributed to the cranial cruciate ligament. And then finally, tibial thrust. Tibial thrust is a modification, let's say, of the cranial drawer sign. You're still looking for instability, but instead of focusing on the femur, you're focusing on the tibia. And so you flex and extend the tarsus, and while putting your finger on the proximal portion of the cranial aspect of the tibia, and while you're flexing and extending that tarsus, the tibia will push your finger cranially, and if that movement is excessive, then that also adds to the diagnosis. The reason why I have air quotes there for excessive is because there are some animals, like for example puppies, who are still growing. They may have a normal amount of tibial thrust or cranial drawer. They don't have cranial cruciate ligament disease. How would you know if that drawer sign or tibial thrust is normal for that patient? Hopefully you have a contralateral normal pelvic limb that you can compare it to, and then you go from there. Now, that's your classical textbook cranial cruciate ligament tear. Radiographs, which you may or may not need to perform depending on the general practitioner and what they're going to do with that case, may or may not be needed. So if all the symptoms I just mentioned, all the physical exam findings I mentioned are in accordance with what you're seeing, that's enough to tell the client, I strongly suspect cranial cruciate ligament rupture. How will you confirm it? Well, radiographs are supplementary. They're not going to show the practitioner the actual ligament itself. They only are going to show you the bony structures, and they'll show you soft tissue, but in a very general sense. What you're looking for on radiographs for a cranial cruciate ligament rupture case is you might see medial buttress. You'll see an increased soft tissue opacity over the medial portion of the stifle. And again, you can compare it to the normal side if you need to. You'll see joint effusion within the stifle joint, both on the cranial aspect of the joint as well as the caudal aspect. You might be able to catch tibial thrust or cranial drawer on the radiograph, depending on the positioning. And if that patient was awake or sedated during the radiographs, you might see a cranial translation of the tibia in relation to the femur. That's how you would describe it on radiographs. So there are things you can see on the radiograph to help you with supporting the diagnosis, but they're not going to be as clear cut as these. Your hands are going to be what's going to. So that was the first part of your question. You also asked about, I think, comorbidities to look out for.
Yeah, so that was part of the next one was, if you get a diagnosis of cruciate tear, important to kind of not stop there and make sure that there aren't other comorbidities. What are common ones that you find?
Yeah, a lot of the dogs that are prone to orthopedic disease in general tend to be the same signalmen that are prone to other conditions. And so the one of the best examples I can give you would be a large breed dog who's maybe older in age, 8, 9, 10 years old. Let's say it's a golden retriever or a German shepherd, and they now have an acute onset of unilateral pelvic limb lameness, and the general practitioner thinks it might be a cruciate tear based on the history, the clinical sign, the physical exam finding. Well, those dogs also are prone to hip disease as well as lumbosacral disease. And that's just the orthopedic on the hind end. I don't know if that patient has a history of pancreatitis, diabetes mellitus. Maybe we've been seeing degenerative myelopathy over the past number of years that has just been subtle and slow moving, insidious, right? So there's a certain signalment that you're looking for dogs that tend to have additional conditions while you're trying to work up the cranial cruciate ligament. This is going to be very different than like a 2-year-old pit bull that has no prior medical history that suddenly is lame in the pelvic limb. You're maybe less suspicious that there's something else going on that either caused the cranial cruciate ligament tear or it just so happens to be there at the same time as the tear. So to bring back the older golden retriever example, let's say that golden retriever has had hip disease forever. And the owners kind of knew that. They diagnosed that with the vet maybe at the age of 3 or 4, something like that. And now the dog hasn't had any orthopedic imaging till now, 8, 9 years old. Well, it's often the case that if I were to receive that case as a specialist and I'm going to start the workup, which will include radiographs not only of the stifle, but also of the tarsus, the pelvis, and the lower spine, it's often the case that I'll see the contralateral hip, so contralateral to the cruciate tear that I'm diagnosing, be way worse in condition. So if the right hip is really bad and I'm seeing a left cranial cruciate ligament tear, I'm wondering if the chronic offloading off the bad hip onto that good leg is now what caused overload of that cranial cruciate ligament rupture. Yeah. And the reason why that matters is because, well, now I'm going to repair that cranial cruciate ligament. We know this animal probably is offloading for years on the repaired leg. Well, what's that going to do to the other side now? And we all know that 50% of dogs within 2 years of diagnosing their first cranial cruciate ligament tear will rupture the second side. Well, that's just one scenario that I've laid out where that dog is at high risk of rupturing that other side because now we're forcing that dog to put its weight on the bad hip, which is now going to put more pressure on their good cranial cruciate ligament, putting more strain on it and prone to tearing it. So that's just one example that's common of many.
And so when you're talking about some of these comorbidities, then I would assume that for every time that we're referring to, for a cranial cruciate or whether we're doing it in-house or not, a complete neurologic exam is paramount.
Yes. So We tend to, as doctors, and we all know this all too well on the human side, when you go see a doctor, are they performing a full physical examination on you, right? And so, the answer probably is no. And so we, as veterinarians, get stuck in the same thing because especially if you're a seasoned veterinarian, you know what you're looking for, you're gonna find it. You've been doing this for decades. Do you have to do a deep oral examination on this patient who's in for lameness? Are you rectaling every single dog that comes through? So we all know that there's physical examinations that are sort of modified based on what you think that patient needs, and also based on things like your work schedule and how backed up you are, and all the logistical things that we deal with as doctors. So, as a specialist, though, I'm being entrusted to not just look at what the diagnosis supposedly might be from the referring veterinarian, but I need to make sure that I'm not being duped, not in a malicious way. I need to make sure that I'm not being so honed in on that stifle that I'm ignoring the rest of the patient and other conditions. And orthopedic and neurologic examinations have a lot of overlap, a lot of overlap. There are neurologic conditions that can look orthopedic and vice versa. And a lot of the dogs that have the signalment of a cranial-cruciate ligament tear also have the signalment for other neurologic diseases like degenerative myelopathy or lumbosacral disease called equine syndrome. So it's very important that not just the general practitioner, but especially the specialist, be as thorough and open-minded when they receive this case as possible, and not just assume that the presumptive diagnosis of cranial-cruciate ligament tear is the diagnosis, and don't presume that is the only thing wrong with that pet. And so yes, a neurologic examination is paramount to these cases as well.
I love it. I love it. So a couple questions, just kind of bringing it back into a summary. Any common avoidable hiccups that you see in referral cases that could be prevented, help out with the workflow?
It's so individualized, let's say, when it comes to hiccups, because even the term has with it a multitude of definitions, right? So, for example, if a general practitioner is fully confident they're diagnosing a full cranial cruciate ligament rupture in this dog, and then by the time they refer to me, I find out this diagnosis occurred 6 months ago, and this dog's been managed with rest and non-steroidal anti-inflammatories and maybe analgesia, and we've been sitting on this for 6 months, and now I'm receiving a dog that has marked muscle atrophy, severe osteoarthritis in that stifle, severe periarticular scar tissue formation. The dog's own mental state, he or she has habituated themselves to basically being three-legged, right? Now I'm thinking, well, why did we wait so long before sending it over? This dog had a great prognosis if I saw them 5 months ago. Now it's got maybe guarded prognosis because it's going to be very hard for me. I can't reverse all those changes to the stifle, even with stabilization through surgery. And now we're going to require a lot more intense rehabilitation post-operatively, which adds not only to cost for the client, but also to a lengthy recovery for that patient, which of course is most important. So the general term or the general thought as a specialist in regard to hiccups are things like that. Is what if the diagnosis was there, what did we do before referral to try and maximize the health of that patient, but then knowing when to say, okay, this isn't working, we need to switch gears and get a bit more heavy duty. So that's one example is the timeline of referral, which you alluded to at the beginning of this conversation was timing wise with referral. Another hiccup would be a patient that has a known history of having perhaps lower back issues or whatever, but when you see them for the cranial cruciate ligament tear as a general practitioner, you work them up for the tear. So maybe baseline blood work, physical exam, stifle radiographs, and then you send them over to the specialist, and the specialist says, well, you have this chronic history of lower back issues. We should radiograph the pelvis or lower spine, and it turns out you've got a osteolytic vertebral mass, right? Well, we've now taken a patient that's had this cancer since, and we put the patient and the client through medications and rechecks, and then finally referral, and then I do a radiograph and I see, well, the issue that you've had that's chronic is here. This didn't happen overnight, right? So As a general practitioner, my advice for that kind of a hiccup is, be as thorough as possible. If this patient has had a known history of lower back issues or whatever it may be back there, and now you're seeing them for a cranial cruciate ligament tear, well, let's screen them at the time of the initial GP consultation prior to, because now that conversation is different with that client. Yes, you have a cranial cruciate ligament rupture, which a surgeon can fix, but now you have this highly suspect neoplastic process in L7. We need to address that if at all. And so those are just two examples of hiccups that I would say.
No, those are great. Before we kind of close, is there anything that we haven't touched on that you want GPs to know to make their surgical referrals smoother?
If you're a general practitioner in, let's say, a new area, maybe you just opened up a new hospital, or maybe you are entering an existing hospital for the first time, and there's a specialty center that the facility will be referring cases to, create the relationship with the specialist they want. Contact the oncologist, the internist, the surgeon. Hey, I'm Dr. Smith. I'm new to the area. I'm going to be referring cases to you. In general, what is it you'd like me to quote clients? Prices, scheduling, timing. What records do you need? Right? What diagnostics do you not want me to perform? What do you want me to perform for maybe lymphoma cases for the oncologist, or diabetes mellitus for the internist, or cranial cruciate ligament? Right? Set up your relationship. Be friendly. We are colleagues, and that collegial work environment is paramount, because that relationship that you set up as a general practitioner with the specialist is not just important for the two of you. It's going to resonate. It resonates to your staff, who has to confirm appointments, send records, do all that kind of stuff. It's going to resonate to the pet, because the pet's going to need optimal care, and the client's going to feel it. If there's tension between you and a specialist, I don't care what anybody says, that client at least knows something's up. They're going to get that vibe either during the referral process or when they get to that specialist. They're going to know something's weird. The vibe here, the tone is different. So set up their relationship. Once you're an established general practitioner in that area, call the specialist, call the ER, say, hey, I want to know what you want me to know, and then, what's your standard GDV cost? What's your standard pyometra cost, right? And then set up that relationship. That way you've got a nice working relationship between all parties involved.
Yeah, that's great advice. I remember when I owned hospitals in Arizona, I always thought of all the specialists as kind of extensions of my team. So the more we knew each other, the better it was for everybody.
Everybody from the folks who keep the hospital clean, to the receptionists, to the doctors, to the practice manager, to the owners, to the specialists, everyone's part of this process. That animal's care, everybody had a piece of that pie. Everybody did something to contribute to that whole journey, and it resonates. You can tell. The pet can tell, the client can tell, your team can tell.
Yeah, I love it. Could not agree more. It's not the doctor that saves the pet. It is the team. It is always the team.
Absolutely.
Can you tell us more? I'm sure all of our viewers want to know more about you and Vetriage. Give us an overview of Vetriage and your work there.
So Vetriage operates through clinical partnerships. We have maybe 1,000 partners across the world, and different facilities, depending on if you're a general practice or a university or a rescue shelter or ER or on-call facility. They leverage us in different ways to that partnership. And that maintains their work-life balance, and it gives clients peace of mind knowing that they can speak to a veterinarian with their perceived emergency and then be given advice for what to do, because chances are they don't have an actual emergency. So that's how Vetriage operates.
Excellent. Last question for you. I know you're global, but also available to all clinics in all 50 states?
Correct. Yeah, teletriage and teleadvice does not establish a veterinary client-patient relationship, nor does it maintain one. And so the goal here is triage and advice only, which is different than telemedicine. Telemedicine involves, typically, depending on the state, a VCPR to be established prior. Teletriage and teleadvice is its own thing. And that's based on the American Veterinary Medical Association guidelines for that.
Awesome. It has been wonderful to have you on the show. I learned a lot. I know our viewers will too. So thank you again, everybody, for watching Vet Watch, only at DVM 360, where what you know today protects everybody tomorrow.